This is the 55th edition of Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. In this edition, we're going to run down some of the most intriguing and impactful research presented at the 2019 annual meeting of the American Society of Hematology in Orlando. Editor-in-Chief of MDH Hematology Oncology, Dr. David Henry, spoke with presenters and authors of the research at the meeting. And Dr. Henry even presented original research that he had been working on. I spoke with Dr. Henry about that as well. And coming up later, of course, is clinical correlation with Dr. Ilana Yurkiewicz. She's here to talk about the human side of hematology oncology care. Her topic this week, survivorship and gratitude. Don't forget that we still have a vast portfolio of coverage from ASH 2019, which is available on our website, mdh.com/hemonc. And of course, all of the abstracts discussed in this edition are available in the show notes section of your particular listening application. I'd also like to take a moment to ask you to leave us a rating or a review if you're listening on Apple Podcasts. We do see your feedback and we take it seriously, and of course, we appreciate you joining us this week. Okay, let's get to our ASH 2019 coverage. The abstracts we'll be discussing today appear in this order. First, Roxadustat in the treatment of anemia in patients with lower risk myelodysplastic syndrome and low red blood cell transfusion burden. In this discussion, I talk with Dr. David Henry. Abstract number 2, ASH19, an anti-CD19 CAR T-cell therapy in patients with relapsed refractory mantle cell lymphoma. For this abstract, Dr. David Henry speaks with Dr. Brian Hill of the Cleveland Clinic. Abstract number 3, also with Dr. Brian Hill, comparative outcomes of relapsed follicular lymphoma patients treated with novel agents, a multi-center analysis. Dr. Henry is joined by Dr. Hill and by lead author, Dr. Allison Winter. Following these 3 abstracts, Dr. Lindsey Roeker and Dr. Anthony Mato, both of Memorial Sloan Kettering, joined Dr. Henry to discuss 4 abstracts that deal with chronic lymphocytic leukemia. The first abstract they discussed is Elevate-TN, Phase 3 study of acalabrutinib combined with obinutuzumab or alone versus obinutuzumab plus chlorambucil in patients with treatment-naïve chronic lymphocytic leukemia. The second abstract that Dr. Roeker and Dr. Mato discussed was ibrutinib and rituximab provides superior clinical outcomes compared to FCR in younger patients with chronic lymphocytic leukemia, an extended follow-up from the E1912 trial. The third abstract they discussed was quantitative analysis of minimal residual disease shows high rates of undetectable MRD after fixed duration chemotherapy-free treatment and serves as surrogate marker for progression-free survival, a prospective analysis of the randomized CLL14 trial. And they finish up with 4-year analysis of Murano study confirms sustained benefit of time-limited venetoclax rituximab in relapsed refractory chronic lymphocytic leukemia. And if you want to jump around to certain research that was discussed in the episode, you can find general timestamps in the show notes wherever notes are found. You can also find the titles and numbers of the abstracts discussed. We begin with abstract number 843 and welcome the host of the show, the editor-in-chief of MDH Hematology Oncology and the lead author of the research, Dr. David Henry. This is Blood and Cancer. Oh, I beat you to it, Dr. David Henry. We're recording at ASH 2019, and I knew that he was going to do that, so I wanted to jump in and take the spotlight. We're looking at the best, hottest abstracts that were presented at the meeting, and I thought, what a better way to start than with yours, and it's about a novel agent. So tell me what you're talking about and what you wrote about and what you talked about.
Well, thank you, Nick. When you're the host of a podcast, you get to immodestly talk about your own presentation. So we're here at the ASH meeting, December 2019 in Orlando, and I was amazed that an abstract I was part of and submitted was not only picked, but picked for oral, no pressure, haven't done one of those in about 10 years. Mm-hmm. And it's entitled Roxadustat in the treatment of anemia in patients with lower risk myelodysplastic syndrome, MDS, and low red blood cell transfusion requirement. So it's a new agent. I'm sure most of our listeners know about the ESAs, Politin alpha, darbepoetin, treating anemia of cancer, treating myelodysplasia, treating renal failure anemia. So that works by that pathway. This different molecule is a HIF-1 alpha stabilizer. So to remind everybody of your biochemistry and what this new mechanism worked out for the past many years and now has a medication. When we're in normal oxygen tension, the HIF-alpha pathway tries to go make red cells, but there's a degrading enzyme that takes it down, so HIF is destroyed. In low oxygen, say you live in Denver, you move from the Northeast to Denver, your oxygen tension goes down, the HIF-alpha molecule is not degraded, and then goes over HIF-alpha to HIF-beta and transcribes on the genes to make more erythropoiesis. And so this is a normal mechanism. Well, this new first-in-class medication, Roxadustat, approved in Japan and China for renal cell anemia, in this trial was used in myelodysplastic syndrome anemia. Same mechanism. It was found to increase native EPO, increase erythropoiesis, markedly decrease hepcidin, which may be its really claim to fame because it removes this inflammatory cytokine block that we see in patients with inflammatory disease like cancer. And lo and behold, in this open-label 24-patient trial of this medication, which is an oral 3 times a week pill, we found a little better than a third of patients who had this low to intermediate risk MDS, low transfusion burden, they became transfusion independent. So that was really probably why it's selected for presentation, to hear about this new molecule, this rediscovered new mechanism, and this efficacy positive trial in these myelodysplastic patients who were transfusion dependent.
So a couple things. The fact that it's novel and the fact that the N was 24 makes me think that, but looking at the results, a lot more to come from this.
A lot more to come. In fact, I'll mention in my presentation tomorrow that there's a double-blind study that has actually been written and started in a 3-to-2 randomization in these same patients using the 2.5 milligram per kilogram oral dose 3 times a week to see if we can actually prove the point that the open-label enthusiasm can be carried forward to a double-blind phase trial.
And safety profile, early findings?
Really very good. The neat thing is that ESA has had a VTE, venous thromboembolism risk. There's no such thing seen in these myelodysplastic patients, no need for IV iron. There were about 20% of patients who had as much as a grade 3 adverse event, but it was diarrhea or shortness of breath, probably due to these patients being sick MDS patients. We'll find out in this placebo-controlled trial.
So appreciate you coming on your own show to talk about your abstract, but we've got a lot of really cool interviews that are coming up next, and just your thoughts on the meeting 2019, what it was like.
Well, that was really interesting. We're halfway through it, and already it promises to be very exciting with new agents, new therapies, new algorithms in various of our hematologic malignancies, benign and malignant. So I'm enjoying it. There's a plenary session about to come up where in CAR T failures, there's actually a therapy for malignant lymphoma, so exciting meeting.
And remember, as you're listening to this, all of our coverage is available at mdh.com/hematology-oncology. There's meeting coverage. You can find all of the ASH stuff and then everything that came subsequently. It's going to be a great year, 2020, for the podcast. We've had just over a year of episodes, which is really exciting. So stay tuned for the best of ASH 2019, including Dr. David Henry interviewing all of the people he thought were interesting with interesting data.
Starting with me.
Starting with you, that's right.
Thanks for listening. Welcome back. I'm Dr. David Henry, and this podcast is Blood and Cancer. And we are here still at the American Society of Hematology meeting 2019 in Orlando, Florida. And I'm delighted to be with Brian Hill, who is at the Cleveland Clinic and Director of Lymphoid Malignancies. Brian, thanks for stopping by to talk for a few minutes.
Thanks for having me.
So we wanted to talk to you in particular, speaking of lymphoid malignancies, and you and I were talking. I have a patient with mantle cell who did very well in the beginning with ibrutinib, and then he relapsed, became pancytopenic, bone marrow full of mantle cell, and currently is enjoying a pretty good response to ibrutinib and venetoclax, but I'm afraid he's destined to fail. And you have a presentation coming up at these meetings in the next couple of days on the ZUMA-2 trial, mantle cell lymphoma, and the CAR T. Could you describe what you did, who the patients were, and as much as you can tell us before your presentation about how the results were?
For sure. Thank you. So, what you describe is pretty typical for mantle cell lymphoma. As you know, it often responds well to initial treatment, and then when it progresses or relapses, is very difficult to treat. Standard therapies with BTK inhibitors, ibrutinib or acalabrutinib or others, is very effective, but also doesn't cure the disease, and eventually people will relapse or progress through that. And we know that those patients have very poor survival, very measured in just months. So the ZUMA-2 clinical trial, which is being presented at this ASH meeting, which I was a co-investigator on, is the first and largest prospective clinical trial for anti-CD19 CAR T-cell therapy for mantle cell lymphoma. And what's unique about this study is that all of the patients who were enrolled, it was actually a requirement to be on the study, had to have been treated with a BTK inhibitor, so ibrutinib or acalabrutinib.
First.
Yeah. So on the study, it's about 70 patients or so. There's extensive prior lines of therapy. Again, everyone had ibrutinib or acalabrutinib. And what we found was that the vast majority of patients enrolled could have their stem cell, or their lymphocytes, I should say. Lymphocytes could be manufactured into CAR T cells with reliably in approximately 3 weeks. And
so it takes about that long to take it out, get the product
correct.
Prepared and back to the patient.
Right. So that period of time is a period of risk for patients because they're waiting for their manufacturing and they can progress. There were a few patients who dropped off from disease progression during that time. But what we found was a remarkably high level of activity, approximately 90% overall response rate.
Really?
With about 2/3 complete remissions, which is really unprecedented for this disease, particularly after BTK failure.
How long is your follow-up so far?
So the longest follow-up patients are about 2 years out. There was a gap of patients in between, and so the median follow-up, I don't want to be misquoted, but I want to say median is in the realm of 12 to 15 months.
So if this pans out, that's really exciting data.
Yeah.
If this pans out, whom then would you think we should refer to a CAR T specialist like you to consider in mantle cell?
Right. So I think basically any patient who has relapsed mantle cell should touch base with a referral specialist who has the access to CAR T cell therapy. We, at our site, will be having an expanded access protocol opening probably as early as January. So very soon we hope to have expanded access protocol because regulatory approval for this may not be until later in the year. So patients really are could be in desperate need of this type of treatment, should be referred.
And the downside, I know this potential for this therapy for adverse effects, and patients sometimes spend weeks to months in the ICU. Was there bad SAE or AE in this patient?
Yeah, so the two major toxicities of this therapy are cytokine release syndrome and neurotoxicity. It's difficult to do this in a very old or infirm patient, so you have to have certain baseline lack of major comorbidities and reasonable performance status. But if you have those things, probably about a third of patients have pretty severe CRS and or cytokine release syndrome. And there can be neurotoxicity, but it's reversible in basically all patients. And there were no deaths from CRS or neurotoxicity.
Well,
yeah.
Very exciting, and we look forward to your presentation. Well, thank you very much for stopping by. We've been talking with Dr. Brian Hill from the Cleveland Clinic. Mantle cell lymphoma, stay tuned. Thanks so much, Brian.
Thanks for having me.
So once again, I'm Dr. David Henry, and we're here at the American Society of Hematology ASH19 meeting in Orlando, Florida. And I'm delighted to be speaking with Dr. Allison Winter, who's at the Cleveland Clinic, and she's a new staff lymphoma expert. Allison, welcome to this podcast. Thanks for coming by.
Thanks for having me.
Well, you're very welcome. And we want to begin by asking you about something you've just done and presenting at this meeting. I understand you have an abstract being presented, I think, in the next day or two on relapsed follicular lymphoma and novel agents, outcomes using this particular patient population, novel agents. So what could you tell us about what you did and what you found in this abstract?
Yeah, so for frontline therapy for follicular lymphoma patients, we have pretty standard immunochemotherapy options that we can mostly agree on, although that's probably being challenged at some of the data that's being presented at this meeting. But when it comes to the relapse setting, there's no consensus of, well, what do we use next and how do we sequence therapies? So we just took a retrospective look at patients treated at multiple academic centers with some of the more novel therapies, and specifically took a look at lenalidomide plus or minus monoclonal antibody and the PI3 kinase inhibitors plus or minus monoclonal antibody, and just looked to see if there were any difference in outcomes. And we did find a significant difference in progression-free survival as well as overall survival when we took a look at the current FDA approvals. So someone who got lenalidomide plus monoclonal antibody was included in our outcomes analysis, or someone who had a PI3 kinase inhibitor monotherapy. And we started the clock at the first novel agent in terms of timing for progression-free survival. So if someone had both novel agents, again, it was from the time of the first novel agent that was used. And we found that those who had the lenalidomide and monoclonal antibody had a progression-free survival of 15 months compared to those with PI3 kinase inhibitor was only 6 months. And again, that was statistically significant. And was also surprised to see that there was an overall survival difference as well. Again, the first group was 120 months compared to 37 months for the PI3 kinase inhibitor monotherapy.
This makes me think of, if I remember the name correctly, the Relevance trial. Was that with the so-called R squared, where it's lenalidomide and monoclonal antibody? And in my own practice, as I'm a generalist, I've been shocked and delightfully impressed with how well this looks. So your abstract and report corroborates that this does work, gives the two together, lenalidomide plus antibody.
Yeah, the large majority of patients, the 43 who had the lenalidomide and monoclonal antibody, the large majority, it was with rituximab, although there were a few who did receive obinutuzumab. But you're right, it's very encouraging results that we saw here.
Any downside? We always think, of course, with these wonderful new tools we have, is there a downside? Did they develop some adverse event that you saw in the combination that not in the monoclonal or the single drug?
So we didn't specifically look at the combination of lenalidomide and rituximab in terms of toxicity compared to just lenalidomide alone. Our entire cohort that we reported on was people who had either plus or minus monoclonal antibody, but when we looked at the outcomes, that's when we limited it to the FDA approvals. But that brings me to a very important point that we found in the abstract, which has to do with toxicity. So how tolerable are these agents?
Yes, yeah. So the toxicity then with the lenalidomide versus the PI3 kinase inhibitor, in my experience, those are harder on people, the PI3 kinase, than for the BTK inhibitors.
Yeah, and that's what we found in our study here. When we looked at reasons for why novel agents were discontinued, we found that 28% of people came off the lenalidomide class because of toxicity, and that was less than the 40% of people who came off of the PI3 kinase inhibitor because of toxicity. Now, there is one caveat here when we talk about PI3 kinase inhibitor therapy, was that the large majority in this study was idelalisib. There was only 3 other patients who it was a newer generation PI3 kinase inhibitor.
Which is a little, in my hearing, I haven't used it yet, but it's a little easier. The diarrhea, the LFT abnormality, maybe rash, not so bad?
Right, that's what we think. So, with every retrospective study, the whole purpose is, hypothesis generating and question generating. So these results can't be translated into the newer, therapies because they might be more tolerable.
Well, I think we'll draw it to a close, and thank you for coming by to talk about your abstract and good luck presentation tomorrow. We've been speaking with Dr. Allison Winter from the Cleveland Clinic, lymphoma specialist. Allison, thanks for stopping by.
Thank you.
And we're back again. I'm Dr. David Henry, your host of the podcast Blood and Cancer, and we're here at ASH, the American Society of Hematology meetings in Orlando, Florida, December 2019. And we want to continue with what's hot at ASH in particular areas, and I'm delighted to be talking with a friend and colleague, Anthony Mato, who's at Memorial Sloan Kettering, and his fellow, Lindsey Roeker, who's also with him today from Memorial Sloan Kettering. Welcome to you both.
Thanks so much.
So what we want to do in this short piece is to talk about, in your area of great expertise, CLL, chronic lymphocytic leukemia, what is interesting to you at these meetings. So Anthony or Lindsey, take it away. You can go back and forth. What was striking you in frontline or relapse?
So I think starting with frontline, there's been a lot of really exciting data presented. Maybe the most exciting right now is Elevate, which is introducing acalabrutinib in the frontline setting and really showing that the drug is active, that patients are doing really, really well. It seems to benefit broad patient populations, kind of advantages seen across all groups, and response rates are really, really high with the drug. So I think there was some speculation that acalabrutinib was going to work in the front line based on the ibrutinib experience, but it's good to have the data to support that.
And I think I'm hearing that the acalabrutinib may be a little safer with regard to atrial fibrillation. Any other reason to use it? Is it a little stronger?
I think it's a good question. It's hard to know without head-to-head randomized data, but the activity is high, the responses are durable, and there will be randomized data coming in the relapse refractory setting. Maybe you want to mention the sort of nuances of the trial design, sort of the BTK plus or minus CD20, which I thought was particularly cool during the presentation, really interesting.
They looked at acala monotherapy, acala with obinutuzumab, and then that was all compared to chlorambucil obinutuzumab. So the trial really wasn't designed to compare acala versus acala obinutuzumab, but they did do some post-trial analyses, and it does look like the acala benefits from the addition of obinutuzumab.
So in the frontline setting, might this be something you would choose first frontline?
Yeah, absolutely.
Yeah. Okay. What else did you think was interesting?
Frontline session yesterday, so we're still processing a lot of the abstracts, but we saw a lot of interesting longer-term follow-up data presented at the meeting. The ECOG 1912 trial, which was ibrutinib Rituxan versus FCR, was like a really important abstract last year because it was one of the first times that the old champion, the old standard of care FCR, was taken on and was beaten by a novel agent in terms of PFS, and the surprise was overall survival. And so everybody said, oh, this is just a fluke because small number of events, but we have another year's worth of follow-up, and the PFS advantage was still maintained, and the overall survival advantage was still maintained, which really supports the paradigm shift of novel agents kind of replacing chemoimmunotherapy in the frontline setting, whether it's FCR or BR. The other thing that I thought was interesting from the frontline setting was the longer-term follow-up of the CLL-14 study, which is a German CLL study group study. And that study looked at obina venetoclax versus ven chlorambucil. Positive result last year, PFS, OS, positive result last year, PFS, but no overall survival advantage. The cool thing about the regimen is that it's a time-limited 12-month therapy. So 6 months of antibody, 12 months of venetoclax. And we didn't have a lot of information about what happens after those 12 months, but now we have up to 36-month progression-free survival, and we know approximately 82% of patients are progression-free. The missing piece of information, and maybe you want to comment on it, is what happens to those patients when they progress, and could you use venetoclax or a BTK inhibitor again? And we saw one abstract today, the updated Murano data. What did you think about that?
So the Murano study was looking at venetoclax rituximab in the relapse refractory setting, and they reported today on 10 patients who had gotten ibrutinib after the venetoclax treatment in the relapse refractory setting, and then some patients who were also retreated with venetoclax. Ibrutinib seems to do relatively well. I believe it was 12 patients total, 10 of whom were evaluable for response and all had responded. There were 2 deaths while on ibrutinib therapy, so I think really understanding what happened there is going to be important.
Sure.
But in terms of the venetoclax therapy after that time limited Ven-R in the relapse refractory setting, the response rate isn't awesome. So I think there is something to be learned there, and we need to figure that out.
Let me come back then to your FCR, because I really hate that combination because it seems to hurt the bone marrow for so long. Is that really something you're kind of putting back on the shelf, FCR, after some of these data?
It's on the shelf, but the cupboard door is not completely closed, and so we still entertain it in young, fit, IGHV mutated, non-del17P patients who don't have a TP53 mutation and are Coombs negative. So you see, we're kind of dicing this up so it's about 5% of patients or less. Those patients might potentially be cured with FCR, but it's 1% or less of our current patient population who are receiving that combo. So I agree, I think it is largely on its way out. Would you agree?
Absolutely. I mean, I'm a third-year fellow, and in the years that we've worked together, I've seen one patient get FCR.
You probably don't even know what FCR is.
I am learning a little bit, but certainly not my go-to.
Don't learn too much. And one other thing you and Anthony said, Lindsey and Anthony, was the mutated, unmutated IGVH thing, of course. The mutated we think is great when we see that. Seems to be that these, especially the novel BTK with antibody combinations, really strikingly better in the unmutated setting. Would you agree with that? So that's the patients where it's a difference.
I think mutated patients do well kind of regardless of what you treat them with.
Right.
So it's more the unmutated patients where that benefit really shines.
Well, I think we've covered, we just wanted to make kind of a vignette from this session with you, and you've covered the frontline setting, what's hot, some of the relapse setting. So I thank you both, Anthony Mato, Lindsey Roeker, both from Memorial Sloan Kettering, CLL specialists. Lindsey the future, Anthony's now. Thank you both for stopping by.
Thanks
Thank
so
you,
much
David.
for having us.
And that concludes our ASH 2019 episode. Remember, you can find links to all of the abstracts discussed, as well as biographical information for the guests in the show notes. We love covering meetings for all of you, but if you think our meeting coverage, specifically with podcasts, could be improved or adjusted, or if there are things that you do like that you want us to keep around, please email us and let us know at podcasts@mdedge.com. Address your email to Nick. That'd be great. I would love to help improve and continually make our meeting coverage as good as it can possibly be. Blood and Cancer. We'll be right back with clinical correlation after this. Welcome back to Blood and Cancer, the official podcast of MDH Hematology Oncology. I am Nick Andrews. It's time for the human side of Hem-Onc Care with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. Today, I'd like to talk about survivorship. Cancer survivorship specifically refers to the period of time after a person is cured, focusing on her life and health, including addressing any physical or psychologic late effects that she might have from either the cancer itself or from its treatment. There's a growing need for providers who can take care of cancer survivors, and that's of course a wonderful testament to the field and its progress. Historically, it hasn't always been clear who the primary provider should be for cancer survivors. Many patients want to stay with their oncologist for years and years, because they're understandably incredibly grateful to them. They saw them from the beginning, and they trust them. Now, there's been more of a shift to train primary care providers to manage issues in survivorship so that the whole spectrum of a person's health can be addressed in the primary care setting where we typically associate that kind of holistic care. I mentioned psychologic issues after cancer or its treatment, and that probably connotes for you a negative. Depression, anxiety, all of this is common after cancer. But today, I wanted to address another psychological issue that was more positive, because lately I've just had a couple of patients back to back who gave me similar heartening accounts of their survivorship stories. For these folks, the psychological impact of surviving cancer was gratitude. I had one woman describe to me how all the pettiness melted away after her cancer diagnosis. The nice part was that even when she got better, the pettiness stayed away. Her attitude was that because she had dealt with real hardship, any other hardship was minor in her eyes. It was a lovely attitude that stayed with her even years after her cancer was long gone. And it made me think about a good exercise, even for those of us who've been lucky not to have suffered serious health conditions. Imagine getting terrible news and having uncertainty about how many days you will even get, and then getting through to the other side. Imagine what it would be like to live every day like that. I share my patients' wise insights because I think we can all benefit from a little less entitlement and a little more gratitude. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that concludes this edition of Blood and Cancer. BNC is hosted by Dr. David Henry. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. The show is produced by Mary Ellen Schneider. All of our podcasts are produced by Editor-in-Chief Ivan Oransky and Executive Editor Kathy Skarbeck, as well as Multimedia Editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio editor, audio engineer, and the voice of MDH Podcasts, Nick Andrews. You've been listening to Blood and Cancer.